Welcome to Cancer Buzz. I'm Summer Johnson. On this episode, we examine comprehensive patient care and how to prioritize whole patient care in a value-based healthcare system.
I think that when you look at what we're called to do in cancer care, it's about making an accurate and precise diagnosis. It's about accessing and providing the most up-to-date treatment, whether you can do it on your own, whether you do it with an academic partner, or whether you do it through referral, and never forgetting that at the center of those efforts is a human being, somebody who has feelings, somebody who has relationships, somebody who needs other people, somebody who needs to be able to pay their bills, somebody who needs to be able to get from one place to another. Transportation is an issue. Somebody who may or may not have adequate resources to purchase their medications.
That's Dr. Randall Oyer, Medical Director of Oncology at Penn Medicine-Lancaster General Health. He'll be back later in the show talking about his program's approach to supportive care services. This is Cancer Buzz, a podcast production of the Association of Community Cancer Centers. Today we're talking about comprehensive cancer care services. A cancer diagnosis is a traumatic experience that forever changes a patient and their loved ones too. In cancer care, we know treating the whole patient improves their quality of life, and not just during treatment. But supportive care services have a large effect on patient outcomes. However, most supportive care services are not reimbursable, and to provide patient-centered comprehensive services, cancer programs must absorb the cost of these services or try to connect patients with community resources, which may or may not exist. The cancer care team weighs the supportive care services that patients and their families may benefit from, and they understand that these needs can change even over the course of care. Dr. Jeffrey Kendall is the Director of Oncology Support Services at the University of Minnesota Cancer Care Center. He specializes in psychosocial oncology and has built several supportive services programs at 6 different cancer centers around the country. According to Dr. Kendall, patient screening can help a program stay cost-efficient, and providing a menu of services to patients, providing exactly what they need, can keep costs down when reimbursement isn't covering the expense.
The University of Minnesota is an NCI-designated comprehensive cancer center and has been for decades. So, we provide the whole range of oncology supportive care. And many people don't know all the components of oncology supportive care, but we have a palliative care team, we have physical and occupational therapy, we have dietitians dedicated to oncology patients, we have chaplains dedicated to oncology patients, social work, psychology, we can refer to our psychiatry colleagues, but also care coordinators and nurses that specifically help our patients navigate through the system, and nurse educators that help educate patients about their illness, about their treatment. So when you think of oncology supportive care, it's actually a broad range of services. It covers so many different aspects. In some cancer centers around the country, even their pain team can be within the oncology supportive care services. Their cancer survivorship program could be under oncology supportive care. Even volunteer programs in some cancer centers are under the oncology supportive care umbrella. And then on top of all that, many cancer centers, especially at our NCI designated comprehensive cancer center level, you'll have researchers researching the impact of cancer on a psychosocial level. So oncology supportive care is a very large umbrella that we work very hard to impact our cancer patients when they need it and how they need it.
Talk to us about a great distress screening program. What can programs do to make it the most effective, right? So it can do what it's meant to do, and that is to properly identify patients who need support and then get them access to what they need.
In my professional opinion, the stress screening program really needs to be integrated within the electronic health record. The way our distress screening program works here is our patients are screened one time per month, and they're screened when they're roomed for an appointment with one of their oncology physicians. The great thing about our screening program is that based on the patient's answers, all of the stress screening questions are on a 1 to 10 scale. So any patient that scores positively on any of those questions, an automatic message goes to the appropriate supportive care professional. So if a cancer patient says they're having trouble with their nutrition, an automatic message within our electronic health system goes to our oncology dietitian. So the oncology dietitians can then follow up with the patient. In an ideal world, they could possibly follow up same day in the clinic, but typically our policy and procedure for this is that they follow up by phone call within a day or two. The benefit of this particular, and this is why I say this is kind of a gold standard for distress screening, is that it satisfies all the requirements. Patients are screened monthly. So in my professional opinion, that's frequently enough that we can address their needs as they change. But it's not so frequent that it becomes a burden to the patient to answer these questions every time they come in or they're handed a piece of paper. The second piece of why I feel this is the gold standard is it's this automatic message to the appropriate oncology supportive care team member. As the psychologist, I don't get messages from the nutrition questions. I get messages from the anxiety and depression questions. So this is meeting the requirement and frankly exceeding the Commission on Cancer requirement, but doing it in a way that it's patient-friendly as well as friendly to the workload of the psychosocial oncology supportive care team.
Walk us through how we overcome the challenges in getting the information from the screening and then connecting the patient to the people or services that he or she needs. The proper processes or how to go about setting up an effective process to do that well and efficiently.
Through our distress screening program, with these messages being created directly from the patient's responses to the questions, that is one method, but that's only one method of many. It's really important that our medical colleagues, our nursing colleagues, that everybody in the cancer program, frankly, from the front desk all the way to the back of the building and back out, all providers, all members of the oncology team should always have this on their radar. When they're talking to patients, when they're evaluating them for their medical concerns, they should also be listening very carefully for any form of psychosocial concern, and not only asking the right questions, but then bringing in the appropriate staff to assist. So a real easy example of this is if in a lot of the community cancer centers around the country, patients will come a half hour early just to talk to the front desk person, the person checking them in.
I imagine.
Yeah, because we become part of their family. And so if a patient comes in and they're talking to the front desk and they say to the person, I've lost like 32 pounds in the last 10 days. Well, that person should be educated enough to know, holy cow, that's a lot of weight. Maybe I should let the dietitian know that information was given to me. So that's a real simple and easy example of everybody, all members of the cancer center should always be listening to our patients and helping them. So that's where when I talk about distress screening, a lot of people feel that distress screening would overtake all previous methods of referral to oncology supportive care. And I always remind people that distress screening is just one pillar of many that helps our oncology patients get the help they need when they need it.
So how can research help justify a psychosocial program, supplemental services, to the overall priorities of a cancer center?
Well, there's been a significant body of research in many of the areas of oncology supportive care. Palliative care, for example, psychology and social work, nutrition, physical therapy. All of these areas already have a significant body of work demonstrating that when you address the psychosocial needs of cancer patients, the medical treatments work better. And it's not that the medical treatments are working better, but a cancer patient that doesn't get to their appointments obviously is going to have a worse outcome. A cancer patient who loses too much weight, hospitalizations and all of those things, these all impact the cancer care of our cancer patients and their families. So stress, reducing the stress, improving depression and reducing anxiety, all of these factors play a role. Research helps us define what patients need what intervention at what time. And that's really where we're moving in many of these bodies of research, because not every cancer patient needs to meet with the psychologist. Not every cancer patient needs to meet with a dietitian. But through research, and where I think we need to go with our research, is defining which patient needs what intervention at what point in time. What are the variables that we can define that tell us this patient needs this care?
One of those supportive services is nutritional counseling and access to it before, during, and after active treatment. Yet today, most cancer care is delivered in the outpatient clinic, a setting where dietitian services are not usually reimbursed. We talked with Kelay Trentham about the value of supportive care. Kelay is an oncology dietitian at MultiCare Regional Cancer Center in Tacoma, Washington. She says cancer nutrition services in her program were born from patient request, but explains how hard it can be to get these particular services covered since it's not widely accepted that nutrition impacts the bigger bottom line. Here's that interview.
Dietitians have long struggled with reimbursement. And if you think about services like speech therapy and physical therapy and occupational therapy, there's reimbursement for all of those services. If there's an appropriate diagnosis, if there's appropriate reason the patient needs to be seen by one of those services, there's coverage. And again, the only thing that Medicare covers for our services is kidney disease and diabetes. And so there's not an acknowledgement that malnutrition in a setting of cancer care is hugely impactful and truly could actually impact the bottom line. And it's just until we get better reimbursement, it is going to be hard for these places to want to bring somebody in and basically just cover the cost of it. But we also have a screening program for our patients. And so one of the things we do is we go through the patients who have screened and appear to be at nutrition risk. That's what our screening indicates for us. And we may add some people on to our schedule to see them throughout the day. And so we spend time with our patients, oftentimes while they're getting their chemotherapy infusions. Sometimes we see patients outside of those appointments, meet with them in a private area in a consult room. What we talk with patients about or help them with really runs the gamut. It can be anything from, I'm a brand new diagnosis and I'm afraid that everything I'm eating might be bad for me, and can you tell me what I should be doing? And as I go into treatment, what should I be thinking about and worrying about? So sort of pre-education prior to treatment, to someone's in the middle of treatment and they've been doing fine, but all of a sudden they're having some side effects and having difficulty with eating or getting enough fluids because they have taste changes or nausea and vomiting, or they're having issues with some chemotherapies, for instance, cause quite a lot of diarrhea, and that can cause dehydration and electrolyte abnormalities. So we might be working with them to help manage those things by changing their diet. And then we may also have patients who the type of treatment they have is something that would impact their ability to eat at some point during treatment. So some of those patients would get feeding tubes placed prior to the start of treatment. So these would be people with head and neck area cancers or esophageal cancer, where we know that radiation to those areas is going to cause swelling, it's going to cause pain, and they're going to have a really hard time eating and swallowing. So we might be working with patients to help them optimize providing their nutrition and their hydration through the tube and, manage that, because that can be a logistical issue for a lot of people. And then we might, at the other end of the spectrum, be working with patients who they've completed their treatment and they're looking forward and they're saying, hey, now what can I do to help reduce my risk of this cancer coming back or getting any other type of cancer? So that's what we tend to call like a cancer survivorship, nutrition consultation. Like, let's talk about what the guidelines are to help you reduce your risk of recurrence or prevent your cancer coming back.
Talk about the role of the nutritionist on the cancer care team and how the nutritionist dietitian plays a role in patient satisfaction and outcomes.
Sometimes people are coming in and here they are, feeling like they're in the fight of their lives. And they're reading a lot of stuff on the internet or they're having friends send them a whole bunch of information. A lot of times the stuff may not be really scientifically based. It might be more hype than it is factual. And they're coming in with this information. They're saying, gosh, I'm hearing that I shouldn't eat this food or I shouldn't have that food or I should follow this type of diet or I'm not going to survive unless I avoid this entire category of foods. And that creates a lot of emotional distress because, here somebody starts to hear this type of stuff and they think, gosh, did everything that I've done in my life up until now cause this cancer? So for our part, we're there to say, first of all, let's look forward. There's not any point in looking backwards because we can't change what's happened before. And also, we didn't always know everything that we know today. We may not have known 5 or 10 years ago about diet and how that might influence someone's risk for cancer. And not all cancers are influenced, for example, by nutrition. There are genetic factors and exposure factors and things like that. So there's a great deal of emotion around, what people might be hearing in the media that may not be totally accurate. And there's also a great deal of grief that can happen when someone has a type of cancer that the treatment impacts their ability to eat foods normally in a more permanent way. So some people, for example, who undergo treatment for head and neck cancer may permanently experience swallow dysfunction such that they can't eat the same textures of foods either a long time after treatment or possibly for the duration after treatment that they used to be able to eat. They may have to have blended solid foods rather than whole solid foods. And they may have to have thickened liquids. And, they're kind of frustrated and grieving that, this part of my life, I used to be able to eat whatever I wanted and now everything has to be modified. So we try to help them process that. We try to help them figure out how they can have some more enjoyment with food. And also, how not to be afraid of food and know and understand that, there's a part of eating that doesn't have to just be about, is it good for you? Is it bad for you? But do I enjoy it? And is it part of my cultural makeup? And is it part of my family traditions? And it's okay to have some enjoyment too. And that's really important to people.
What difference does nutrition make in patient outcomes? I would imagine that you, after you do screening, you find some patients who have some social determinants to getting good nutrition. Talk about the value of the services that you provide to a patient undergoing treatment.
One of the things that we have quite a bit of information about is that people who are malnourished in the course of cancer treatment tend to be at higher risk for hospital admissions, readmissions, not doing well, experiencing greater treatment toxicity. So, people who are experiencing significant treatment toxicity may have to have their treatments held or their treatment doses reduced. And that's always going to be something that impacts their outcome. It's been documented that for every day that radiation treatment has to be held, you reduce the chances of control by 1%. If you have a patient who has to be hospitalized for severe dehydration, malnutrition, related type of things, or even severe reaction to the chemotherapy that they're also having at the same time as radiation, and they're not able to get to their radiation for several days, you've actually reduced the percentage of control that they have. So when we can intervene and work with people to try to improve their nutrition, improve their hydration, sometimes that may mean working with other members of our team to help them get access to food, whether that's social work or getting them engaged with Meals on Wheels or other meal services, or we may be, addressing the access issue. Oftentimes it's not just access, but it may be side effects and how that impacts somebody's acceptance of food and their ability to eat. So, but like I said, we know that treatment toxicity is very much impacted by people who are losing weight and not eating well. And so that's where we intervene and try to turn that around and help reduce their risk of ending up in the hospital, ending up in the ER, having to come into clinic for hydration repeatedly. And that impacts their quality of life as well.
Dr. Oyer is a passionate advocate for whole patient care, and he is also ACCC's president-elect. Here's what he said on translating the value of comprehensive care. Dr. Oyer, why don't you tell us a little bit about your background in cancer care?
I'm a medical oncologist. I've been in practice for more than 3 decades. I work in a community cancer center that's part of the University of Pennsylvania. I work in Lancaster, Pennsylvania, where our population are our friends, our neighbors, our family, and our approach to providing comprehensive cancer care is that we want to take care of our patients like they are our family. We want to make sure that people have holistic care so that they can have access to care, so that they can get through their care, so that they can withstand the side effects of treatment and recover to the best possible life after treatment. So we're very high on science and up-to-date medical care, but we're really focused on making sure that we have all the services that help people get the medical treatment they need, that they get through the medical treatment that they get, and that they recover.
When we talk about whole patient care, what we're really talking about is addressing the human element to patient care, right? There's an emotional aspect to this, and we're dealing with humans and their families who are forever changed by a cancer diagnosis and that resulting journey. How do you think whole patient care plays a role in patient satisfaction and eventual outcomes?
Oh, I think it's fundamental to patient satisfaction and to outcome. To begin with, we want to be sure that we take care of the person who has the cancer, and we include the family in that, not just the cancer. We know from studies that often it's the social determinants of health that undermine the benefits of what we can do with advanced science. And we know that patient satisfaction has a lot to do with making the human connection with a person, with a patient, with a family, and understanding who they are as a person, understanding what their values are, what they want to accomplish with treatment, making sure that we utilize shared decision-making, which to us means that people have enough information to understand what is their diagnosis, what is their prognosis, what's their stage of diagnosis, what are the available treatment options, what are the potential limitations of treatment, what are the potential benefits of treatment, at what cost, at what side effects, so that patients can be part of decision-making, so that they feel that they've been able to choose what's best for them. And we know that from a lot of studies that shared decision-making leads to improved patient satisfaction. And it probably also leads to improved patient outcomes, because it's often that the patient or the family may know what's best at a given time for a given individual.
You said that patients rely on all of these services, and I imagine the bottom line is that patients need these services. We know this. The research supports it. In fact, the service is required by accrediting organizations. So the big question is how can cancer programs make the case for adding uncompensated supportive services in the value-based environment?
We have to look at what our patients' needs are when we make any programmatic decision, any investment in care services. And there are some services that neither the program can function without, nor the patient and family can function without. And at this point, we no longer look at these individual services based upon whether or not we can bill for them or whether or not we can reimburse for them. I work for a community hospital that has a very deep commitment to the community, a mission to care for our patients, all of their needs, and we understand that there's a cost involved in this. For us, it's an investment that simply gets patients to their treatment, gets them through their treatment, and makes it possible for patients to get better. We don't look at it through a lens of reimbursement, and we can't. When we see a new cancer patient, and we're part of the oncology care model, so we do, as we're required, provide the 13-point Institute of Medicine care plan. And in the care plan, which is the patient's care plan, when they're given their initial outline of what the possible course of care might be, we tell them what their proposed chemotherapy is, what the potential impact would be on their quality of life, what the intent of the treatment would be, whether it's curative or palliative, whether it's directed at simply symptom control. But as part of that document, we provide a list of the supportive care services that we provide, and we have a little asterisk next to the ones that are separately billed, with the idea that there's no charge to do everything else on the list: access a social worker, access a financial counselor, access a nurse navigator, access a research nurse. Those services are not billed, but if a patient wants a private session with a behavioral health counselor, there's a little asterisk noting that that's a billed service, the way the cancer center would send out a bill to see a physician. Other services that are done without charge include seeing the chaplain. We make a distinction for the minority of supportive services for which there is billing, but we put out the whole list so that people are able to access them. We often suggest services to patients. We have standard screening criteria so that we can identify people who are likely to need and benefit from a social worker, a chaplain, or a financial counselor, distress screening, so that we have automatic referrals and we provide them. We ask. We certainly don't force and can't force people to access services that they may not be ready for or may not wish to access, but we make it easy for them to do so.
But can you add supportive care services and do it in a cost-efficient way?
That's a very good question. In a cost-efficient way? Well, it depends upon whose investment you're talking about. We do it in our Cancer Institute as an investment in our patients' well-being, but also an investment in the practice so that we're supporting the entire team by making sure that supportive care services are provided by professionals, but being provided by the right professionals. For example, we want everyone to, so to speak, work at the top of his or her license. So we want the physician to be doing diagnostic and therapeutic decision-making that only she can do. We want the nurses or nurse navigators to be doing symptom assessment, diagnosis, or management, or other nursing work that only a registered nurse can do, so that we're taking the spiritual support and we're taking that out of the physician visit or out of the nursing education visit, and that's in a spiritual care visit with a chaplain and the social workers. Not that the physician or the nurse wouldn't address distress. We're all holistic. We all care and relate to our patients as humans, making the human connection. But we're taking the big portion of that work out of the physician visit or out of the nursing visit, and we're taking it into a social work visit so that the social worker is using what they're trained to do. Assess suicidality, assess home needs, assess relationships in the home, assess practical needs. They're trained to do that. They know what to do. They have access to lists and lists of community supports and connections. They're good at it. They're efficient at it. So in a sense, we do employ a large number of people, which is a big expense for our Cancer Institute. But it also lines up our team in a way that makes the physician and nursing work more targeted and more efficient in a way so that people are doing what they're uniquely trained to do.
You're pretty passionate about supportive services. Why do you think that is?
We know that unmet social needs undermine the advances of cancer treatment. So we really have to take care of all of the patient's needs to make sure that they get better. And it's not just the tumor or the cancer getting better. it's the whole person getting better. So we look at it as part of our treatment. And in our Cancer Institute, we look for and we hire people who share the same passion, who share the same mission. We know that top-notch cancer care really requires a highly functioning team for the best care. You have to know not only who does what on your team, you also have to know who knows what. You have to develop methods to communicate among team members, trust among team members, so that you understand that you're getting accurate, timely, precise reports from one team member, one discipline to another, that you share a common vision, a common mindset for what you come to work to do, and that you have backup behavior where if somebody sees a need that's not being met, they're either going to try to meet that themselves, jump in there and help where they see a gap, or they're going to bring somebody else in to do it.
We'd like to thank Dr. Oyer, Dr. Kendall, and Kelay Trentham for their insight today. To find more resources on comprehensive oncology care, check out the show notes for this episode on the ACCC website at accc-cancer.org/podcast. Next time on Cancer Buzz, we'll examine immunotherapy, transitioning patients on immunotherapy treatments into survivorship, and the differences in coordination and communication for immuno-oncology. We know you're a busy professional, and we want to thank you for listening. If you like the show, please share it with your colleagues. It helps us create even more content for you. Until next time, for the Cancer Buzz team, I'm Summer Johnson.